Welcome, welcome, welcome. Like I said, I hope everybody fared pretty well for for the storm. I saw some more areas might get hit again this weekend. I'm so sorry. Um, okay,
Okay.
okay. Um, so I just
Hey,
kind of
just so
know.
you know, sorry to interrupt you.
No worries.
Marcy's gonna be logging on soon. She had a long drive home.
Yep, gotcha. Awesome, thank you. You got to turn your camera back on, Aiden. And Mariah,
Sorry.
Aquana. No worries. All right. So week four. So I posted the PowerPoints. I hope everybody was able to get them. Um, and so the PowerPoints are in announcements. If you let's see. Um, I think the announcements go through right away, right? If I post an announcement, it goes right to your email or something, right? Doesn't it? Yes, maybe. Um,
I get a notification from Canvas that you posted in the announcements.
Oh, okay. All right, cool. All right. So, week four, we look about week four, it's all about communication. So, how do communication techniques and understanding sensory and cognitive changes influence the care we provide to our wonderful older adults? So I will share my screen so you guys can see the PowerPoints. Make sure I share the right screen. Perfect. All right. Can you all see the PowerPoints? All right, cool. All right. I didn't take my glasses off. Um, so all right, so again, HESI highlights communication. We'll talk about some neurocognitive disorders as well, Alzheimer's, and other forms of dementia, Parkinson's disease. We'll talk about delirium as well and the difference between delirium and dementia. Oops. All right. Um, I missed it. So for this week, it's going to be chapters 5 and 10 in your basic geriatric nursing book, and then chapter 43 in your concepts book. All right. So communication. To be effective, communication needs to be an active two-way process with an exchange of clear, concise, accurate, timely, usable information between patients and healthcare professionals. So that's what we do, right? We communicate, even in nursing school, right? You communicate with your classmates, with your instructors, with administration, with your, patients that you see at clinical. And so that is how we build those relationships, right? With our patients. Also have to document patient care, right? So that the care that you provide to your patients, we make sure that we document that. And then we provide safe transitions of care. So transitions of care is when a patient is transferring from one type of a facility or a unit to another one, right? So whether it's from, say, ICU to a step down unit in the hospital, or even from the emergency room to a med surg unit, whatever, or it could be between different levels of care, like if I'm going from the hospital to a rehab facility or a long-term care setting. So those are especially important, making sure that we're providing for that safe transition. Communication includes all the ways that we exchange information. So it's our speech, how we talk to each other. It's writing, so think emails, texts, charting. It's our body language, right? Body language is a big part of how we communicate. Our gestures, and even in some cases, symbols. So we'll start with chapter 5. So we have the different types of communication, right? So we have verbal, we have nonverbal, we have written, and we have symbolic, right? And so verbal communication, pretty basic, right? It's us talking to each other, having a conversation, or in some cases, it could just be giving, note with no, expectation of a response, but it could be even giving commands, that kind of thing. Nonverbal communication is everything else, right? So give me some examples of nonverbal communication.
Nodding your head,
Showing,
Okay, shaking your head. All right.
hand,
Facial expressions.
Facial expressions. Absolutely.
hand
Absolutely.
gestures,
I'm sorry.
hand gestures,
Hand gestures.
Like any
Um,
kind of like body language, you know?
yeah, any type of body language.
eye contact,
Um, say that again.
eye contact.
Eye contact. Yep, that's a big one, right? And what do we know about eye contact among different cultures?
It could come off disrespectful,
Disrespectful.
staring at somebody.
Right, right. So here in the United States, we generally um, we use eye contact, right? That's part of our culture. And we generally think of it being disrespectful, right? If somebody doesn't maintain eye contact with us. However, like you said, in other cultures, right, it could be considered disrespectful. So we have to be aware of that. So with that, how we have to have congruence, right, between our verbal and our nonverbal, right? So, I sit here and we have our meetings every Wednesday afternoon, and I try to make sure that we're engaged and everything is good, right? And I'm a hand talker, so sometimes I try to keep my hands below my camera. So even though you see my body movement, you won't see my hands going all over the place. But what if I sat here like this and lectured to you?
Makes it
What
seem
kind of
like you're
impression does that
uninterested.
give you?
You're uninterested.
I'm uninterested, right? Whether you get it or not, yeah, right? That's what it is, right? And how would that make you feel if you were on the receiving end of that? Besides that,
Disrespected.
I'm uninterested.
Like you're wasting my time. You don't want to be here. I don't want to be here.
Exactly, right? And I know this has always been, I'm one of those, I have to really pay attention to my face, because I forget sometimes that, that's what you see. I always know what it looks like. It's easy when you're on camera, right? Because I can see myself when I'm talking to you. So all of those things are super, super important. Making sure that, we are matching our nonverbal with our verbal communication. And so when I like this question, the question asks, which type of communication do you think patients are more likely to believe, the verbal or the nonverbal?
Nonverbal.
Nonverbal.
Nonverbal, right? Because they're looking at you, right? They're like, oh, there's something going on, right? It could even be things, and I know I've done it. It could even be like you go into a client's room and you're talking to them, and all of a sudden they just want to tell you their whole life story, and you're like looking down at your watch and you're fidgeting, and you're like, I really need to be somewhere else right now, right? And they can pick up on that, right? So we have to be careful with how we portray that.
I think it works hand in hand though,
I'm
because
sorry. Yeah.
I think it works hand in hand because like I know for me specifically, like I guess because I'm a mom, I could be doing 4 or 5 different things and you still have my full attention,
Mm-hmm.
but like
Mm-hmm.
I'm still just doing different things. So it's like it's
Mm-hmm.
verbal and like verbally I'm still having a conversation with you. My back is just turned because I'm getting diapers, cleaning this, doing this. So that's why I said I think it kind of goes hand in hand also.
Right. But we just have to be respectful, right? Because, we never know necessarily how somebody is receiving that information, right? And no, I understand 100%. And as a mom, as a nurse, multitasking is going to be part of your life forever, right? So yeah, absolutely, you're right. It doesn't necessarily mean that you're not paying attention, right? We just have to look to see how it um,
It's received from
Perceived.
the patient.
There
Yeah.
you go. Perfect. Perfect. Other things too. One of the big one is touch. So touch is also a form of communication, right? And we all kind of, it's a basic human need, right? Some people are very touchy-feely, others are a little bit less touchy-feely, right? And so when we look at older adults may suffer from what we call touch deprivation, right? They don't have anybody to help them meet that need for human contact or human touch, right? So, think about, your patient that's in a long-term care setting, maybe that has lost their spouse, and they're alone and they don't have anybody for that physical contact. And so, you try to use touch and provide comfort. And a lot of, I'm a touch. I'll touch your shoulder, I'll touch your arm, and it just kind of, sometimes it can be very comforting. The one time we do have to be careful with the use of touch, and just this is something that, is when we have dementia patients or agitated patients, confused patients, patients that are in pain, that could kind of increase their frustration, their agitation. So we do have to be very careful with the use of touch in that population. But generally speaking, touch is okay. Always ask permission. That is one thing. Respecting personal space is going to be, part of that nonverbal communication as well. Um, People have different levels of personal space, I guess would be the appropriate term. Um, we got used to with COVID, right? Staying 6 feet away. So we kind of, got to that point. But anywhere, generally between 4 and 18 inches is what we consider our personal space. Don't really like having that invaded. And so we have to kind of really, be careful with that. Has anybody ever, been around somebody who likes to be like really up close to you when they're talking? How does that make you feel? And I'm not talking about a kid, like I'm not talking about your child, like I'm talking
Really
about,
uncomfortable. Really uncomfortable.
right? It
Personal
can make some
space.
people really uncomfortable. Okay. So yes, so right, I went to the doctor's once and my, I couldn't see my typical nurse practitioner. Didn't have an appointment available. I would think I was sick or something like that. But um, and so I had to see one of the other providers, and I'm sick. And so, as a nurse, when you're sick, you really don't want anybody in your face. But she was like right here when she was talking to me, and I was like, I kept trying to go backwards, and she just wasn't moving. So there are hints that you're getting too close to somebody, right? And so we just have to be really, really careful with that. Um, so, other things, as nurses too, we like to wake people up in the middle of the night, be cautious with getting in their face, right? When you're waking them up to give them medicines or, getting their vital signs, that kind of thing as well. But lots of good reasons for touch, in that personal space. This is one a lot of people have problems with. And then I'm not going to lie, even sometimes I have problems with this as well. Is the use of silence. Okay. So there's, we have what we call active listening. Okay. And these are different techniques that we can use to ensure that we are really showing that we're listening to our patients, that we care. And so that listening and hearing them, right, is that first step in the therapeutic communication. Silence is just saying nothing. All right. And so silence is part of active communication. And a lot of people are uncomfortable with silence, right? Um, so it's even, especially when we're talking with older adults, whether they, have hearing deficits or they even just some time to process the question or the information that they're trying to give you, right? Silence is okay. And so it just helps to, people to focus on a point of a discussion, right? So that we get away from that continuous talking. And I have a hard time. I feel like sometimes this, even 10 seconds of silence can feel like forever. But it's also if somebody is experiencing strong emotions, maybe they're upset, they've just had a bad, I don't know what the word, maybe a bad diagnosis or something along those lines. They've lost a loved one or something else has happened, right? Sometimes just sitting with somebody and being present with them, right, can be very comforting in a time of need for our patients or our clients. And it doesn't require us to say anything, right? Sometimes it's just sitting with them, letting them express their emotions. Anybody else have that issue? I don't know. Silence to me sometimes, I don't know if it's, my ADD or something, but I have to have noise. Even when I'm like studying or even doing other stuff, I have to have something in the background.
Yeah, I have to have something playing in the background if I'm studying. If it's too silent, ugh.
hmm I get lost. I'll start getting lost in my own head, like thinking about everything else that I need to do. So we have that therapeutic communication. And I know you've probably heard this term before, but therapeutic communication, right? That's part of building that therapeutic relationship with our clients. It's used to gather information about their health status. And, again, it's part of building that therapeutic relationship with our clients and our patients so that we can really get to know them and understand what their needs are. We always address our elderly population with respect, making sure that we are providing for dignity as well with our communication. Um, so communication steps. So these are really important, right? When we look at, how we communicate with people, listen actively and maintain eye contact. And that's probably one of the biggest things that we need to do. And just like I was saying, walk into that one patient's room and they just want to tell you their whole life story. And you're like, oh my gosh, what did I just walk into? Right. And you're like, I don't have an hour to stay in here. Um, but that therapeutic communication and those active listening skills are super important. So it's maintaining eye contact and listening actively, right? Really hearing what they're saying, responding with empathy, not with sympathy, right? We want to be able to understand, right, what that person is going through without, showing sympathy. Acknowledge them. Okay. So there's different ways that you can acknowledge their response. It could be as simple as saying yes or no. It could be, using words like, uh-huh, tell me more, go on with what you're saying. It could be even things like, repeating back to them or paraphrasing so that you make sure that you hear that information correctly. Um, and then validate their feelings. That is something that is really important too, regardless of what they're feeling, what they're saying, validate it. If people want to be heard, they want you to know, they want to know that you're hearing them. And sometimes, they just need to talk about their feelings, talk about what is going on with them. And so, we want to help them and we want to validate that. So, some of the ways that we can say things, okay? So, when you walk into your patient's room, she's crying. You sit down across from her, you make eye contact. She tells you the doctor just told her that her biopsy results were positive for cancer. So, which of these responses would be the most therapeutic? So I'm sorry to hear that. Let me get you some educational materials about cancer treatment. I can see you're upset. Tell me more about how you're feeling. Or would you like me to call your family to come and sit with you? And then last, we have that doctor is not a good communicator. He should have stayed to tell you more about your prognosis. So which of those is going to be the most therapeutic response?
The
The
second
second
one.
one?
Okay, the second one. Absolutely. I can see you're upset. Tell me more about how you are feeling. This, it helps to build that therapeutic relationship. It shows empathy, right? And it's allowing them to verbalize their feelings and try to just get, some of those things out. Good job. This is always a good one too. What are the barriers to communication? All right. So, what are some physical factors or physical problems that are barriers to communication?
Deafness.
Okay, deafness, absolutely.
Even sometimes blindness because they can't read your lips and be able to formulate what you're saying if they are hard of hearing as well.
Okay,
Someone that's mute.
someone that's mute. Okay. What about,
Um,
oh, go ahead.
like uh like cognitive issues like dementia or Alzheimer's.
Okay, dementia or Alzheimer's, absolutely. Um, Pain is another one. If you're in a lot of pain, are you really listening to what somebody is telling you? You're just, if you're like me, you're like, just go away and let me deal with my pain. I don't want to talk about it right now. Um, but even extreme fatigue, think about times when you're really, really tired, right? And how that affects, right, your ability to communicate certain disease processes. Social and cultural backgrounds can also affect communication, right? If
But,
we don't
but
speak the same language. Go ahead, Joseph,
that's what I was about to say.
right? We don't speak the same language. That's a huge communication barrier, right? So these are some of those barriers that we are going to come across. Um, so when we talk to patients with patient communication and teaching, we want to use simple language. We want to confirm that they understand. All right. So we don't want to use medical jargon. And I know you're going to go through this whole nursing program. We're going to teach you a lot of big words. And then I sit here and tell you don't use those big words with your clients, right? Okay. It's okay to use them with your coworkers, your fellow, nurses and other people. But when we're talking with our patients, we want to be really careful in not using that medical jargon and medical slang as well. That's another thing that we need to try to avoid. Unfamiliar medication names. So, sometimes, that may be a little bit more difficult, right? Because we're going to have to do education about their medications, right? And so just being careful with that, making sure that we're really kind of giving them the information behind that. When we do our education, we always, always, always reinforce it. Give them something that they can hold on to. So whether it's printed materials, it could be, um, it could be, trying to think of what I was trying to say. It could be a pamphlet, um, just depends. And we always give the printed materials in their native language. Okay. And so you can, there's ways to find the material that's needed in their native language. We don't want to give real complex instructions because that can be confusing.
I had
Does
to give
any
someone information before in the ER how to do a test, and she didn't understand even verbally. So I found a video to show her how to do the particular test that she had to do, and she understood that better.
Okay. Yeah, that's an excellent way too, right? Sometimes if you see it, you're like, sometimes it sounds worse than it actually is, right? So yeah, perfect. Um, I forgot what I was going to say. Um, oh, I know what I was going to say. You ever pick up a prescription from the pharmacy and you get that really thick packet of information? Has anybody ever read that? No. It is like what? Like the tiniest print possible. Um, and like so many words, right? And it's a lot of medical jargon that's usually printed out from what we call the PDR, which is the physician's desk reference, which is a whole lot of information. And it's, a lot harder to understand. So we want to avoid doing that. So other than UTI and MSS, what are some other medical terms that that you're learning that you might
Myocardial
use?
infarction.
Okay, myocardial infarction. That's a good
Oh
one.
Lord, that was a good one today.
That was a good one. So what is a myocardial infarction?
Heart attack.
A heart attack. Awesome. What about, I'm trying to think of some, um, UTI, we have CAUTIs, we have, um, what else?
How about intermittent claudication?
Intermittent claudication. There you go. So lots of big words, right? A pick line, right? If you came up to me and said, and I didn't know, you said, oh, we're going to just put a pick line in. Well, what is a pick line? I don't know what a pick line is, right? Some people might not even know what an IV is. All right. So we have to be really careful with how we choose those words and try to just use more like layman's terms when we're using, when we're communicating. Other things too, be careful how when we're looking at some of our, when we talk about some of our patients, especially when we're trying to use simple words, words that can understand. But we also, when working the adults, and I'm going to tell you a couple of my pet peeves. All right. Um, Adults don't wear diapers. Adults do not wear diapers. What do they use?
Briefs.
They use briefs. Or even you can
Depends.
say depend. There you go. You can say depends. Okay, that's a trade name for something, right? For the brand. Okay, but we don't use diapers. I mean, they technically are diapers, but it's demeaning, right?
Yeah, it makes
Um,
them feel less.
Right. So be careful with that. And that's probably I mean, I have a couple pet peeves, but that is one of my big ones, right? It's a huge dignity issue.
Hmm.
And so we want to be careful with that. And I'm bad for this, and I know I'll wrap myself out in a heartbeat. Um, we really shouldn't use the term sweetie, honey, things like that. I use love a lot. Um, and I have had to like stop myself because I'll go to say it and I'm like, nope, we can't do that. And it's not, and I don't mean it in a disrespectful way, but that doesn't mean that it's not received in a disrespectful way, right? Um, all right, so who has heard of aphasia before? Has anybody heard of aphasia before? All right, cool.
Yes.
So what is aphasia?
Difficulty swallowing.
Nope.
It's difficulty formulating words, like difficulty speaking,
Speaking.
and
The
typically see
difficulty.
signs of that
Yeah,
after a stroke.
Yeah, it's
dysphagia is
dysphagia, difficult
typically
swallowing.
swallowing.
Yes.
I
Yeah.
get them
So,
confused.
yep, aphasia. And so, yeah, and I've had to train myself to say dysphagia so that I can differentiate between dysphagia and dysphagia. So, yes. But yeah, so aphasia is a loss of ability to use or understand words. Okay, so there's different types of aphasia that occur. It doesn't, ooh, excuse me. It does not mean necessarily affect their intellectual function. Okay, so there's something that we have to know as well. What are some causes of aphasia?
Strokes.
Strokes. Yes,
Parkinson's,
absolutely. I'm sorry.
TBI.
Parkinson disease.
Parkinson's, TBI, absolutely. So, anything that really affects that central nervous system can lead to aphasia. So, like I said, there's different types of aphasia. So, expressive aphasia affects speech only. Okay. So, I can't express myself. Okay. Receptive aphasia affects language comprehension. Okay. So, expressive, I can't express myself. And then with receptive, I can't understand. All right. So, there are differences in that. And so these patients that have aphasia, especially post-stroke or TBI, something along those lines, they're going to work with a speech therapist. All right. And that speech therapist is going to help
The 5 minute time.
I'm sorry.
Oh, my bad.
So that speech therapist is going to help them to learn how to communicate, right? Whether it's, understanding or expressing. So when we work with patients that have aphasia, then we want to use simple messages, simple sentences. We want to um, use communication boards or visual aids. So we can use printed materials. We can use a whiteboard. We also have communication boards that we can use. And there's a variety of different communication boards that are out there. The one in this picture is a little bit, it's got a lot of stuff on there. But communication boards, there's a variety of different ones out there. And a lot of times it's whatever the client or the patient becomes comfortable using, or even, what there's available. But communication boards can be very helpful, right? You can go in and you can have your communication board and ask them if they're hungry, if they're thirsty, if they need to use the restroom. Yes, Naomi.
What would be what would be an example of like expressive aphasia? Sorry. I know it might be
Um,
the question, but
no, you're fine. So not being able to communicate. So,
like I know it's
um,
not being able to express yourself, but like how?
Because they can't get the words out.
yeah, or they don't know the words. So,
Okay, I see
yeah,
what you're saying now.
yeah. So like,
Or if you have a stroke, your muscles in your mouth probably won't help you get the words out clearly.
mhm,
You know what I mean?
mhm.
You have people that speak in mumbles, or very
Okay,
low and can't really open up their mouth all the way because of the
okay.
stroke.
And you'll
Mhm.
notice that they get really frustrated with themselves sometimes because they know what they want to say, they just can't get it out.
Okay.
Mhm.
And
Right. They
I
can't,
just
it's
asked
like you
because when
can't find the words to say
when I
what you need to say.
when I thought expressive, I thought like face expression. So I'm like,
Aha.
okay, like you okay. Thanks, Joe.
Gotcha.
Thanks, Jackie.
Gotcha. Yes. So, my uncle, this was a few years ago, he passed away, but he had had a stroke. And so, he had expressive aphasia. And so he didn't have any loss of cognitive function. So, like, if you gave him a communication board, a computer, an iPad, like, he could tell you what he wanted. He just couldn't say it. So, that was his biggest frustration. Or when he did try to say it, it wouldn't come out the way that he wanted to. And so, like they were saying, it can be very frustrating for those patients, right? Because they're like, they know what they want in their head, they know what they want, they just can't tell you. Um, and like I said, with receptive, they have problems with comprehension. So you could repeat yourself, bunches of time, and they still may not be able to understand what you're saying. So it's two different things. Um, And so this is why some of those nonverbal communication techniques, like the visual aids, the whiteboards, the communication boards, can be very effective, right, in helping to kind of figure it out. Dementia. So dementia can cause both cognitive as well as language deficits. All right. And the person with dementia, they don't have any control over this. This is the part of that disease process. So that memory loss affects their ability to communicate. So, they can't follow complex instructions. So we're better asking yes or no questions, limiting their choices. So working with dementia patients, and raise your hand if you're a CNA. Okay. Worked with dementia patients before. So you get really busy. It's morning and I got to get my residents up and we got to do all this stuff. Right. And so you may go in and be like, okay, here's your dementia patient. You're like, all right, Mrs. Jones, time to get up. We're going to brush your teeth. We're going to get dressed. And then go to the dining room for breakfast. Okay. When somebody that's not cognitively impaired or doesn't have dementia, like if I was laying in the bed because I just had a hip replacement, right? I may be able to understand that. Like, okay, I got to get up, I got to get dressed, I got to brush my teeth, and then I'm going to go to the dining room, right? Somebody with dementia, they're not going to be able to follow that, right? We need to give them one instruction at a time. Like, okay, wake up, right? Then let's go brush our teeth. And once we're done brushing the teeth, okay, now let's get dressed, right? We need to be very, very specific about what we do. So we want to, short, simple instructions. We also want to limit their choices, all right, because that can be confusing for them too. If we give them too many choices, right? Here's 10 shirts, pick which shirt you want to wear. That may lead to frustration, okay? So be really careful. Confusion in that dementia patient can lead to them, can lead to agitation. And, that's we're trying to avoid that. We don't want them to get agitated. We're trying to keep them calm, right? But if they're not able to communicate because of that dementia and they get confused or even frustrated, they can become agitated. We never argue with our dementia patients, although you may want to sometimes, okay? But we do try to redirect them, all right? One thing about dementia patients is you want to meet them where they are, not where you are, okay? You may be in a long-term care facility, and that dementia patient may have been in that facility for a couple of years, all right? But maybe in their mind, they're at home sitting on their couch watching TV, or they're at the bus stop waiting for a bus to go to work, okay? So we have to meet them where they are. We also be careful with our tone of voice, because patients that have dementia are also very sensitive to nonverbal cues. All right. And so if your tone of voice starts to rise or changes, then they may actually sense your frustration and become more agitated or upset. So we talked about language, right? So if patient doesn't speak the same language that I speak, we want to find out what language the patient is most comfortable with, right? And so who are the best to provide um, as a go-between and somebody that does not speak our language? What should we do? We have a patient that doesn't speak our language. Who do we go to?
Get a
Or
translator, maybe?
I didn't hear you, Felicia. I'm sorry.
A translator?
A translator,
Family
right?
member.
A professional translator. Why should we not use family members?
Sometimes they can't, they're not reliable sources when it comes to translating for medical diagnosis, and the patient may not understand everything that the family member is relaying back.
Okay. They may not be a good, reliable source. HIPAA could be an issue as well if we don't have permission, right, to speak to the family member. We also could potentially have misinformation, and it may not just be a lack of understanding. It could be that the family member is purposely providing false information to the other family member. Okay. So that is why we try to avoid family members. Now, in an emergency situation, right, and that's all we have, we can, but we want to be very careful. So always try to get that professional interpreter around. Um, we could do some visual aids as well, kind of like a communication chart, right? Because a lot of our daily functioning, right, is the same. If we show a picture, we want to also, avoid the technical language that, like we talked about. And even when using an interpreter, you want to focus on the patient, not the interpreter. All right. So that's something that's a little bit different as well. Um, it just depends. Most interpreters aren't going to be live. Some of them might be live, but a lot of them are usually going to be through like the telephone or another communication device. And then we have our documentation. Yes, Jacqueline, that's a really good point. Yes, a lot of people are using their phone to translate. So I was at work, this was a while ago, and with our housekeepers, I don't speak Spanish, hence the last name. Okay. But I married into it. Um, but most of our housekeepers don't speak English, they speak Spanish. And so one of them had come up to ask me I think they had cut their finger or something and they wanted an alcohol pad and a Band-Aid. And she had the phone out and she hit the button and she asked me for an alcohol pad and a Band-Aid, which is great. I was like, okay, that's cool. I thought that was really neat. Another facility, we used iPads as well. We had a deaf mute patient uh, who only communicated with American Sign Language. And so I don't know what the program is on the iPad or the app on the iPad. But when he needed to talk with us, he would, get on the iPad, he would sign to her or him. And then they would tell us what he was asking. So it's really great, really high functioning. I loved it. And we only used it for the sign language. So I didn't get a chance to look to see what other language what if there were I'm sure there's other languages, but I thought it was really cool. And then we have our documenting patient care. So who has gotten a chance at clinicals to do documentation? Anybody? Do you guys practice like nurses' notes or anything like that?
We've been
Yes.
practicing
Yes,
nurse
ma'am.
notes, but we haven't done anything in the electronic records yet.
Okay, but you got to practice your nurses' notes. Okay, good. So we do have to be careful, right, with our documentation. Remember that your documentation is legal documents. All right. Anything that you put in that chart is a legal document. So your documentation should be objective. You want to avoid any subjectiveness in your documentation, clear, accurate. Um, if the patient says something and you want to put it in your note, go ahead and put it in quotations. Same thing with providers. If the provider tells you something, you want to put that in your notes as well. So let's look at this note and tell me, what are some errors in this nurse's note? All right, so we have at about 3:05, this nurse walked into Mrs. Jones's room and saw her laying on the floor beside her bed. She was mad. She began screaming as loud as she could at this nurse and using rude language about being on the call late forever. There was a lot of liquid all over the floor, and this nurse could tell that she had spilled her water cup on purpose.
This
First of all,
So,
she was saying that she could tell that she had spilled her water cup on purpose. She can't tell that it was spilled on purpose. That's not something you can just say.
Accusing her.
right. Is that objective? No,
No.
right? It's subjective. What else?
She
Anything
said
else?
she was mad. That's subjective too.
Right. Okay. All right. So
And
let's see what,
also not being specific about the rude language that was being used.
right, because rude language can be subjective as well, too, right? Like if I said, if don't get me in trouble, but if I said, all right, everybody be quiet, right? To me, that's, I mean, I don't think that's rude, but that could be rude, taken rudely to somebody, right? All right. So good job. So at about 3:05. So about 3:05.
To be
Why is about 3:05 not good?
Because
guessing
that's
because
not
it's
a
not sure.
definitive time.
Right. It's
That's a
not
guess
clear. It's
time.
not concise, right?
Hmm.
She was mad, and you guys got that right. Absolutely, right? Because that's subjective. She began screaming as loud as she could.
Oh yeah.
Probably, I've seen this where people have done this and the lady isn't the patient never screamed or even yelled, right? But now we're just trying to paint a poor picture.
Isn't that false
Use
documentation?
mm-hmm. Mm-hmm. Using rude language about being on the call late forever, right? So again, not specific, right? We want to be as specific as possible. And like you said, this nurse could tell that she had spilt her water cup on purpose. You can't tell, right? Did the cup tell you that she spilled it on purpose? Did,
Hmm.
the little, florb is like, I watched her, she spilled it. So good job. All right, so this is another one. Have you guys started using S-bar yet?
A little.
Yes, awesome. So S-bar, I love this little picture. I love rubber duckies. But anyway, um, so before you call the provider, get your ducks in a row. And so we have S-bar and we have the I-S-bar. I don't know if you have heard of I-S-bar. But we use ISBAR, especially when we're communicating with providers. Okay. Um, and so and that I in the IS bar, that's the introduction. All right. That is, hi, my name is Jennifer. I'm calling about, Mr. Jones in room one. Okay. So the I is just the introduction, who I am, and who I'm calling about. And then we go into the SBAR, the S bar part of it. So, the situation, right? This is what is happening at the current time with our client, the background, what led up to it, and then your assessment. What do you think is wrong? And then what do you recommend to correct the problem, right? So I'm just trying to think of a good one. So, um, let's say, okay, situation, Mr. Jones, we found Mr. Jones on the floor. Okay. The circumstances leading up to this could be, Mr. Jones had a stroke, 3 weeks ago. He's here for therapy. He, decided that he was going to get up or he started to ambulate. He got up without assistance and he fell going to the restroom. Okay, whatever the situation was. And let's say maybe he hit his head when he fell. So the problem is that now that he hit his head, even though his neuro checks are okay, still want to get him checked out. So my recommendation is that we send him out to get an x-ray done and get evaluated at the emergency room, right? The really basic, okay, but that's kind of how it would go. So again, your situation was what happened, why am I calling, what led up to me calling, and your assessment is your vital signs, right? All of that good stuff. And then what your recommendation is, what do you think we can do? And so recommendations could be, a lab, it could be an x-ray, maybe we need a medication, or it could be that we need to transfer to a different level of care, that kind of thing. All right. And so that will bring us to chapter 10. Chapter 10 is about cognition and perception. And so with this, we're going to talk a little bit more about, um, cognitive perceptual functioning and things like that. But before we do, I'll go ahead and give you guys a break. So it's 3:55. Be back at 4:05.
Hey, Jackie,
What's up?
you know your last name is a name. It's a cartoon strip.
Don't you even. You're going to talk about Rupert the Bear right now, aren't you?
Hmm.
And it's a
My whole life I've heard that. My whole life I've heard that.
and it's a poet that I like when I Milk and Honey.
Okay.
I think her last name is Rupert too.
Okay.
You look
Um,
exhausted, girl.
I am. I am. It's been a stressful couple days.
girl.
Did anybody get
Literally,
an
like
email?
around my house is all ice, and I walked outside. Like I looked outside this morning, and I'm like, nope, there's no way. There's no way.
I
I'm not
feel
doing
you.
this.
Someone
They-
said something.
Somebody put the trash can there. Did anybody get an email about we can't wear we gotta wear uniform on Zoom? My bad, y'all.
That's what I was told in the beginning when we first started
I
school.
thought all we had to do was show our IDs like this.
No, it's
No.
on. It's only
Whoever
certain
put this
instructors
trash can
because
here, I'm moving it. Fuck out of here. Why would y'all do that?
Wait,
it's
we
certain
have to wear
instructors.
uniform for
Man, I
what?
was getting moved. I'm not playing these games with people.
Wait, what? Where's this at?
No, it's
We have.
certain
Hey,
instructors
y'all.
because my other classmates they gotta have on uniforms and be at the table sitting up, not in bed and everything.
Excuse me?
Yeah, I wear my
I know,
uniform
I see
shirt.
that. I'm about to pick them, but I put my trash can here and somebody moved it, and this was where I was parked at all week.
Tell
So I was,
Sydney.
yeah, I was behind you. So I'm gonna back up because somebody moved my trash can. I parked right here and somebody moved it. I don't know why they did that. No, y'all parked in front of me. So somebody
Go
moved it and
off.
put their trash
Go
can
off.
here. Oh, well, I'm about to back up, and so y'all can park there. So I don't know who moved my trash can.
She going in, baby.
My bad, y'all.
Aiden, like, go off, go off.
Ain't it ain't shit.
What you say? Girl, it's like parking words on my block. I fucking dug myself out. Somebody gonna move my trash can, and no, I'm not playing them games. I
No,
dug
I wouldn't
myself out.
either.
Spent all them
Go
hours.
off, baby. Do you?
That's not ours.
The one thing I'm grateful
That's
for is
yours.
that I actually have a driveway, so that way, even if when I
There
do
goes
shut it
ours.
out, people can't steal my shit.
No, that's
Jackie,
theirs.
Uh, Maisha, you know what I forgot to ask him?
who D?
Right,
Hello.
Professor D. What was our group gonna do when they ain't
No,
got no
they don't.
patient?
My landlord got to talk to them
Oh,
because
they
this is
can
about
go
to
up
be a
there tomorrow
problem.
and get it.
Oh, okay.
They can go up there tomorrow or Friday to get it because it's going to be posted on the door.
Okay. There's that answer because I thought
Yeah,
about
no,
that.
they don't move at all. They need to move it off the street.
I have to go up tomorrow to get my patients since I
This
didn't
is
do it.
ridiculous. I'm over it.
Yeah,
Yeah, and just check
that's
it,
what I was
sure your
thinking.
patient's still there because a lot of patients
They
left.
said them cards been sitting there since the
Yeah.
summertime of last year.
What was I doing?
Hello. My bad, y'all. I forgot I was unmuted. Did y'all get the email about we gotta wear scrubs?
I
I'm looking
saw
for it
that
right now.
from Bonnie, right? Not Bonnie. The new Sarah.
That's Bonnie. Her name's
That's
No,
Bonnie.
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 You
Her
said
name
it right.
Bonnie.
So
Okay.
was that for like yesterday's Zoom meeting when they called us off?
No,
No.
they said from now on we gotta show our. I don't know why they said that, but from now on we gotta wear our Fortis uniform. We can't be on Zoom without it on anymore.
It
That's
depends
what
on
I.
your teacher. It
Oh yeah, because
it,
I'm about to say we didn't get an email.
it depends on your teacher because people show up in pajamas, I think, and I'm not sure. I'm not even going to sit here like I don't know. I wear a shirt. And again, it
I told
depends
my
on the
son when he
teacher.
left, I went and put the trash can down. So you knew I
I
dug myself out.
I know specifically for this class, Miss Martinez said as long as we have appropriate clothing on, like she doesn't want us in
And I
pajamas
said, "Excuse me, did
or
you
like
just hear? I
shirtless
did.
or
Because y'all
whatever.
know I parked there.
And I think that's the issue. Some people coming on there looking all kind of
I
Raggedy.
mean, I just had my tank top on. She didn't say nothing, so I'm pretty sure, that was good.
She's more lenient
But
than
you
my
went
other
and put that
classmates.
shirt on, I see.
Yeah, I gotta
It
go.
did.
Yo, soon as class is over, I'm going straight to work. I gotta go to work.
Mm.
Do y'all have class in the morning too?
Yeah, we had clinicals.
I don't know why I can't hear.
Is your laptop completely muted?
Shaquana, you're from Florida?
Oh,
I'm
Joe,
I'm from Virginia.
we don't have clinical tomorrow.
Virginia.
We're doing the med surge exam tomorrow.
Oh
What
Lord.
Oh,
this
She
is
was
first?
Jackie
asking for
White,
this. Oh,
Jackie.
she was asking for tomorrow morning or this?
No,
Yeah.
I was asking this
Oh,
They're
morning, did
tomorrow
y'all have
morning.
class
Nah,
we're
this
we
morning?
only got the
supposed to
test. Yeah.
we're supposed to go in at our scheduled lab times, and that's when she's gonna give us our
Exam.
unit
Yep.
exam. So like whoever's in group A will go at their 8 o'clock time, and then group B at their 10 o'clock time, and that's when we'll do our unit exam for med
She
surge.
said she want to make sure
Jackie,
that
did you
Group
have
A don't speak to Group B
a
about
study
the
guide for that or
test.
no?
I do. I can send you it.
Is this
Please and
y'all
thank you,
first
Jackie.
exam?
Who y'all med surge teacher?
Mrs. Holmes.
Yeah.
We're in Scranton, PA.
Yeah, we're in Scranton.
Okay, this y'all first exam for med surge.
Yes.
Yes.
Yeah.
Okay. I took my first exam for med surge. Yesterday I had got 81.
Congratulations.
Congrats.
Thank you. I was scared because I was like, oh gracious, med surge be head.
We were supposed to do it on Tuesday, but we had a snow day.
We
A
still
hell of
ain't
a
got our
feeling.
score.
Is everybody up here LPN?
Yeah.
Yes.
Because I know some programs in Florida are in programs too.
That's crazy.
What's
Thank
crazy
you,
is the
Jackie.
fact that we have 2 unit exams tomorrow now because we got to do med surge and then Pharm 2 right after. Yeah,
Not
we're
already
doing
in
Pharm 2's
pharmacology
exam
too.
tomorrow.
Oh yeah, farm, yeah.
We do got farms tomorrow. Ooh, Lord.
I'm glad
Yeah,
my
remember we didn't do it last week.
Jeez.
Oh
Yep,
yeah, I
you
did
right.
mine last week. Farm and then care. Of course, this class from last week too. Because I had IV therapy this morning and then had to come take a nap and get up here.
We do IV on Friday.
On
Well,
Fridays, we
the
got
clinical
clinicals.
is Friday, but then the Simmon labs are one's on Friday, one's on Wednesday.
And that's still stupid to me because they could have did all the IV stuff on Friday and shut up.
That's how we did
Agreed.
That's
ours.
how ours is too.
We did it well, last month we did everything on Friday.
Well,
Our IV
the way
is on
Dr.
Monday.
Maurer explained it is apparently like one person that's not even in our like current class that's in IV therapy. One person complained that it made the day too late in the day. So they split it up, the IV and the lab and the
It's
sim.
still late now. It don't
That's
matter.
what Dr. Maurer said.
Shit.
My IV clinicals on Mondays, and then my care to older adult is on Fridays.
Okay.
Yeah, I got school Monday through Friday, literally. Y'all probably do too.
I don't have class on Friday because I finished farm, but next mod I'll have class Monday through Friday.
Okay, I did have my
Oh,
first
we gonna
farm
miss
exam
Stevens,
last
Lord
week.
have mercy.
When
It
does
wasn't
everybody
bad like I thought it would be. The exam, I thought it was gonna be bad, but it wasn't.
the one we just took or your farm?
Both.
Well, yeah, the one we just took wasn't bad, but it was
Uh-uh.
stuff up there that the one for geriatrics. It was some stuff up there I don't recall even going over.
Same.
What happened?
It was some stuff on the geriatric exam that I don't that we don't recall even going over.
I had a meeting with Miss Martin because I missed passing it by one question. And so I had a meeting with her and it was so stupid. Like you could tell I was exhausted when I took that because they're like the one especially it says like keep the bed in the lowest position and the wheels unlocked. Like I as a CNA know that you never keep the wheels unlocked for a bed.
Yeah.
So I could tell that I was
That's
just
right.
tired and
You
trying to
probably
get through
read
the
it
exam.
too fast. When you said lowest position, you probably thought that was just it, but you probably didn't read the whole question. I mean, the whole
Right,
answer. Yeah.
right. I caught my eyes like getting heavy and closing on me so many times through that exam, and I was just like yawning my way through it
Well, that's
because it was
okay.
a
The
long day.
thing I
Like
didn't
for a
remember was
clinical,
the population questions.
Oh yeah, I remember
The
this.
general population, the
Uh-huh.
health
no,
population, the it was five
pub
of them though.
the
I know it was
public
five.
health, the public health is what was getting me the
Organization something too. It was like something like or yeah, I remember that.
It was all nursing, public nursing, occupational nursing,
Uh-huh.
all of that.
Not I
Yeah,
think
the
that was
public nursing is what got me on a lot
uh,
of questions.
yeah.
We're just going to make it better moving forward.
Yeah, you got time to redeem yourself.
Thank you.
Yeah.
Oh,
And
hey,
we are
Miss
going to do that.
Martinez.
Absolutely.
And we're back.
All
We
right.
are back. All right. So, again, chapter 10. Chapter 10 is all about cognition and perception. Okay. So, this is going to be chapter 10 in your geriatric textbook or your basic geriatric nursing textbook. So we'll start with some visual changes. Um, so we know visual changes occur for a variety of reasons, right? Could be the normal process of aging, but they do occur. So we have farsightedness, we have night blindness, and we have cataracts. So farsightedness, is what we call presbyopia. It is caused by a loss of elasticity in the lens, and that results in the decrease in the power of accommodation. So, farsightedness, what does farsightedness mean? If I'm farsighted, what does that mean?
The closer you are to
Let's see if
with
you can't
farsightedness, the
Can't see
closer you
things
are to
close
can't
up.
see
something, it's
far away.
harder for you to see.
Let me close up, yeah.
Right, very good. Night blindness is the decreased ability to respond to changes in light. So, having difficulty, especially at night, or in dark areas, right? Seeing if you ever notice older people have to have all the lights on, right, to see. Um, and then cataracts, that is the decreased ability to respond. I'm sorry, the clouding of the lens that results in blurred vision as well as sensitivity to glare. So I had cataracts. I had early onset cataracts, so I had cataract surgery. Oh, it was amazing. It was amazing. I went from wearing glasses my whole life to not wearing glasses. I wear reading glasses, but that's it.
Mhm.
Um, so lots of changes as we get older. So this is macular degeneration. And so macular degeneration, what do you think would be an issue if we had a patient that was, this is what their vision looked like? What are some issues that you could see with that?
They would get
Can't
scared
recognize
because
you.
they don't know who's coming towards them.
Hmm.
Okay, they could get scared because they don't know what's coming towards them. What else?
Ambulation.
I'm sorry,
Ambulation.
ambulation, right? That's a trip hazard right there, right? You're not able to see if there's something on the floor in front of you, right? That could potentially cause some issues, right? So yes, absolutely. They can't see your face, right? So they don't know what you look like. They can hear your voice, right? They can sense your presence, right? But they can't see your face. So, even that, we look at that nonverbal communication, right? They can't see it. What about this is what diabetic retinopathy looks like. So with diabetic retinopathy, they have patchy vision, right? So look at, even doing some of your ADLs could be very difficult, right? If this is what your vision looked like. Glaucoma is what we call is more like a tunnel vision. All right. So glaucoma, we lose peripheral vision, right? And so that also too can affect your ADLs. It can affect walking, driving, right? Imagine driving and you don't have any peripheral, you have a loss of your peripheral vision. Um, you can't see things that, are kind of coming at you from the side, right? So that also can be a huge issue. Then we have hearing loss. Hearing loss is your what we call your presbycusis. All right, so it's age-related hearing loss. Affects 2 out of 3 Americans over the age of 70, so pretty significant amount of people. Um, so presbycusis, sorry, it's a form of sensory neural hearing loss caused by changes in the auditory nerve. It causes loss of the ability to hear high frequency sounds. So high frequency voices are harder to hear. All right. They do much better with low pitched sounds. They can hear those a lot better. Some of our speech sounds like S and sh are not audible to them. Background noises, I don't know if anybody has ever, been around somebody that has difficulty hearing, right? But the TV on or even just normal environmental noise, right, can be very difficult for them to hear what you're saying. May have trouble talking on the phone. That's another, trying to listen and have a conversation on the phone. They may not have that, may have some difficulty with that. And one of the big things is hearing loss sometimes can be mistaken for cognitive impairment. So why do you think somebody that can't hear very well, why would that be mistaken for cognitive impairment?
They might just assume that the person's not understanding what's being said to them rather than the fact that they're just having difficulty hearing.
Right. Right. Because, they may have misheard your, question and answered it inappropriately. So, of course, we're going to think, okay, maybe they have some cognitive impairment rather than the fact that they just didn't hear what I said. Other things, what people don't or can't hear very well. What'd you say? Can you repeat what you said? So, even having trouble following conversations, right? Especially if more than one person is talking, complaining that other people are mumbling, right? Well, not mumbling, I promise, So yeah, or, like I said, repeatedly asking somebody to repeat what they're saying. And so again, like I said, it can be often mistaken for cognitive impairment. So we always want to assess their hearing, right, to see how they're hearing so that we can make changes in how we're presenting information to them, to, ensure that they are listening or they're hearing us, and that they are understanding and processing what we're saying. So memory loss, and aging. Okay. So some degree of forgetfulness or memory loss with aging is common and expected. Okay. So what are some normal things? I mean, even think about some of the things that you do, and you're not older. Okay. But what are some normal memory loss type things?
Like not knowing the
Medication.
exact date that it is, like the date.
Okay.
Like
Not knowing the exact date it is. Okay.
like today's the 28th, I would have you could have told me it was like the 24th and I would have believed you.
Gotcha. Okay.
Looking
Okay,
for
that's
your
a good
car
one.
keys.
Oh my gosh, car keys.
Taking medications at the appropriate times, like on
Yeah.
time.
Okay. Yeah, car keys is one. And I'll do that myself, and I'm not old
Mhm.
yet, but I'll be like, did I take my medicine today?
Bro.
And I have to really think, I'm like, oh, I don't know. And I don't want to double up, and I'm like, oh my gosh, did I take it?
Glasses.
Um,
If we take them off, we don't know.
Oh
Sometimes we can't
Lord.
remember.
Go through that every day.
Thank you, Joseph. I do that all the time.
All the
All the
time.
time. I was at work one night and I was in frantic panic mode because I was trying to chart and I was like, couldn't figure out where I put my glasses. And of course, I'd go up here because, sometimes I'll just flip them on top of my head and they weren't there. And my coworker is just laughing. And I'm like, okay, what is so funny? Why is this? I had hung my glasses in my scrub top and that's where they were.
Mm.
Um,
I've looked for
so
my phone with it in my hand.
d- yes. Okay. So I've done that too. That's probably the most
Don't
embarrassing thing
judge me,
when I can
Maisha.
find my phone. I'm like, I did that. I was on the phone with my daughter one time and I was like walking around the house and she heard me. She said something and I'm like, hold on a second, Stephanie. I said, I'm trying to find my phone. She was like, what, Mom? I was like, I'm trying to find my phone. Like, I don't know where I put it.
But
She's
you
like,
on
aren't
the
we
phone.
talking on your phone? And I'm like, so yeah, that has happened to me. That is very
Even going
embarrassing.
into a room specifically for something, and by the time you make it to that room, you're like, wait a second, what did I come in here for?
Exactly. So it happens to all of us, right? So we do have some normal things that happen to us. What would be an example of an abnormal memory loss?
Forgetting your
People
name,
Forgetting your name. Okay.
forgetting people.
People. Your
forgetting where
name,
you
your
live.
address. Go ahead, Marcy. I'm sorry.
No, you said it. I said forgetting where you live. You said address, so same
Yeah.
thing.
So, these are just kind of some things, right, that, we look at um, abnormal memory loss that, again, forgetting who your spouse is, your kids, where you live, all of that stuff. Short-term memory loss, or I'm sorry, recall may take longer as the speed of information processing slows down with age. This is why, we talked about silence earlier, right? When working with the older adults, you ask them a question. Oh, I'm so sorry. When we ask a question, right, sometimes we need to give them a little bit of time to, process the information, right, before we answer. So, that silence sometimes is there. Short-term memory loss. This is forgetting recent events or learned information. So this is more common in our older adults. Actually, it's more common than long-term memory loss, right? So this is more of your, forgetting. Um, I don't, you're, forgetting where you live, your address, some more short-term memory loss. Oh, I forgot I had an appointment today, right? Even though I booked it yesterday, that kind of thing. Whereas long-term memory loss, this is forgetting events or relationships from the less common. All right. So when we think of dementia and Alzheimer's disease, it's a progressive backwards. Okay. So your short-term memory losses first, but you maintain a lot of your long-term memories. And so the part of probably one of the hardest things to deal with Alzheimer's is having these elderly people, especially elderly women, asking for their moms or their dads, right? Because that's where they think that they are. They remember the long term, they don't remember the short term.
Excuse me, question is long-term memory sometimes are triggered, right?
Yes, yes, sometimes they can be triggered. Yes. And amnesia is just a general term for partial or total loss of memory that can be caused by a brain injury, an illness, side effects of medications, drugs, aging. It could also be a trauma response, right? We don't want to remember, right, what happened. So, variety of different reasons why amnesia can occur. So, cognitive assessment. So there's different types of, or there's different assessment tools that we can use to do a cognitive assessment in our elderly population. And one of them is the MINSI, which is your mini mental state exam. It monitors cognitive changes over time. And these are usually done by providers. But it does score it on a 0 to 30, 0 being the lowest, 30 is the highest level of cognitive function. So basically, it's, the the higher the better. The higher the score, the better. The mini cog test tests memory recall as well as what we call visual spatial skills. Um, but again, your MIMSI, you may use a MIMSI, um, but generally then it's, something that providers use to, again, monitor those changes over a period of time. So this is part of the mini cog test. So what we'll do is we'll have the client draw a clock. All right. And so this is the changes that you'll see as somebody progresses, with Alzheimer's disease. So in early Alzheimer's disease, you can kind of see, right? They have all the numbers. Okay. And I think it's 11 o'clock, right? In moderate, you can see, right, we started off not too bad, right, but kind of went off a little bit. And then in that severe Alzheimer's, you can see we're nowhere, right? It's a completely progressive downgrade. In that. And that is one part of the test, is to have them draw that clock. And so this just shows you the level, how it starts to decline. And we'll do word recall too. So, you'll give them a set of words, you'll have them, do some other stuff, and then you'll ask them, to repeat those words back to you, to see if they can remember. All right. Delirium. Oh my gosh. I thought I hit silence. All right, there we go. Um, so there is a difference between delirium and dementia. So dementia is a progressive disorder or just a progressive disease, right? There's no cure for it. It is going to progress through the stages and can't reverse it. We can't cure it. With delirium is something that is potentially reversible. Oh, it is reversible, all right, if it is recognized. And so delirium, they'll have disturbances in their cognition, attention, memory, as well as perception. And it's usually caused by a physiologic process that affects the autonomic nervous system. And I'll give you an example in a second. But again, it is reversible to baseline. So we can reverse the delirium. We just have to recognize it and, address the changes that are occurring. So one of the biggest ones that with delirium, that can occur is we have, what is it called? It's called ICU something. Oh my gosh, my brain just went blank. I think it's just ICU delirium. And imagine you're sick, okay, and you're older, all right, and something has happened, whether you've had a stroke, you've had a heart attack, maybe even had a trauma or something else, and you're in the ICU. Has anybody ever been to an ICU, even just to like visit or just kind of see what the environment is like? So a couple of you know.
Yeah.
So everybody knows what a regular hospital floor looks like, right? You got usually one tour room, you get a nice door, right? You get some privacy. So ICU, all right. For one, they have glass doors, okay, so that the nurses can always see into your room, all right. Most of them, I mean, they will have some sort of curtains or something to pull for patient privacy during care and things, okay. But for the most part, there's glass doors, so everybody can see in your room. There's lights, there's IV pumps, there's ventilators, and ventilators are always making noise. There's lots of providers that are coming in and out. So it's a very busy environment. Okay. Then there's not a lot of peace and quiet, so to speak. Okay. And why do we tell you when you're hospital, get as much rest as possible, right? But yet they're always going in and, drawing blood and taking vital signs, right? And doing all of this other stuff. Um, So, it's caused, so that delirium can be caused by overstimulation from lack of sleep. And again, we can reverse them to baseline, try to get some of the overstimulation away. And that will help them. Reorientation is really important with these people as well when they are delirious, so that we're just providing constant reassurance, constant reorientation. Um, so why am I delirious? Um, we're not going to do this, but all right. So here we go. Some other causes. So drug use. So certain medications can cause delirium. So we want to look if they've had any recent changes in their medications. Electrolyte imbalances, so sodium, magnesium, potassium, so calcium, geez. Lack of drugs, right? So maybe they had a missed medication or medication that they didn't take, an infection. All right. So look for UTIs or respiratory infections or any other signs of inflammation. Reduce the sensory input. Um, Intracranial problems, so head injury, history of stroke, urinary retention, or fecal impaction can also lead to delirium. And then chest pain, abnormal heart rhythms, that also. So you can see the acronym here is delirium. All right. And make this bigger so we can all see it. So we have an 88-year-old man. He presents to the ED with complaints of weakness and noted confusion by his daughter. Vital signs 100 degrees Fahrenheit, blood pressure 89 over 57, pulse is 122, respirations are 24, and he has a pulse oxygen 95% on room air. The daughter reports that he had developed a GI illness accompanied by several episodes of vomiting over the last 2 days. The patient responds easily to voice and touch. The daughter informs the nurse that prior to the emergency room, the patient was trying to pick apples off the tree as he had done as a child and grab fruit in the air. The patient can follow simple commands and move all extremities independently, but requires one person standby assistance during ambulation. Patient denies pain at present. Bilateral radial pulses are palpable and regular. Bilateral pedal pulses are palpable but weak to touch. Skin is cool to touch with capillary refill greater than 3 seconds on bilateral toes. Mucous membranes are pale. Skin is warm and dry to touch. No diaphoresis noted. Patient denies any chest pain at present. Lungs auscultated with no adventitious breath sounds noted. Abdomen flat and soft to touch. Patient cannot remember the last time he ate or drank anything. Bowel sounds loud and auscultated times 4 quadrants. When patient is assisted to the commode, he voids approximately 250 mLs of concentrated amber urine. Patient denies pain, urgency, or burning with urination. His diagnoses include hypertension and type 2 diabetes. An IV is placed in the right AC fossa and saline locked for use. Which cues here are important? All right. So which you can go ahead.
The
The
blood
low
pressure
blood.
is one of them.
Okay. What else?
The amber urine.
Amber urine. Okay.
Capillary refill greater than 3.
Okay.
Higher respirations,
Higher
elevated respiration
respiration.
level.
Okay.
Slight temperature.
Okay.
Blood pressure is low.
Blood pressure is low. Pulse is high. Respirations are high. Okay.
The confusion.
Confusion. All right.
Oh, and the faint pedal pulses.
And the faint pedal pulses. All right. So let's go. Whoops. All right. So we're reviewing the client's assessment data. Complete the diagram by identifying the choices below to specify what condition the client is most likely experiencing, 2 actions the nurse should take to address the condition, and 2 parameters the nurse should monitor to assess the client's progress.
We definitely want to request
for the
draw the
order.
blood work.
Yeah, the electric light blood work.
Okay, electrolyte blood work. Okay.
Um, hmm.
We need one more.
Administer a fluid bolus.
Okay. So we want to do a fluid bolus and we want to draw labs for
Electrical.
Blood work.
electrolytes.
Electrolyte and
I'm
blood
trying to
work.
get as close to my computer as possible. Okay. So and then what two potential conditions do we think that they're
Dehydration.
experiencing?
Dehydration.
Dehydration
Dehydration.
and dementia.
Okay. And then what parameters are we going to monitor?
Blood pressure.
Okay.
And the EKG.
Okay.
The
Blood pressure,
EKG or
EKG.
ECG?
Same thing.
Oh,
It,
all right,
yeah,
my bad.
it is. It is. It's ECG is the correct one, but we use EKG as well. All
If
right.
if we're putting dehydration, wouldn't we monitor the urine output?
Mm-hmm.
So, all right, what was it? The actions that we took? I know we requested blood work, and what was the second one?
The fluid bolus.
The fluid bolus.
The foot.
Yeah, you're right. Urine output needs to be monitored.
Mm-hmm.
But the fluid, oh,
So
because
when
of
we request a
dehydrated.
Foley catheter, and we
Not
watching out for the
necessarily.
output.
Well, they already
Not
went. Didn't
necessarily if
they
he was
already
already
go to the
voiding.
bathroom? They already
Yeah, he's
urinated.
voiding by himself, so he wouldn't need a Foley catheter. He's not retaining urine. We're just trying to see.
And when you're given a bolus, don't you have to monitor blood pressure?
Mm-hmm.
Intravenously?
Blood pressure is
Yeah,
going to has to be
Yeah, because your
monitored,
blood pressure could go too low.
Oh,
and
you're
his
right.
blood
this
pressure is
class just
low.
became exciting.
Yeah, because the
So
bolus make it go. That's when it's go fast, right?
Yeah.
The bolus. That's the
Because
one
the
that's
bolus going to drop in just like it's going to. They're open. It's wide open.
yeah.
Mm-hmm.
Mm-hmm.
All right, let's see.
I'm ready.
All right.
I'm at a sign on my phone.
All right. So
yep.
the actions, we're gonna do IV fluid bolus, and we're gonna draw those electrolytes.
Woo!
Dehydration is the most common the
Okay.
most condition or most likely
And the
condition,
blood
sorry.
pressure and urine output.
Mhm.
Yep.
Yep.
So good job.
Sometimes this can be confusing because it all kind of meets the criteria, but I guess you have to sit there and decipher which one is the most important.
Important. Yeah.
Mm-hmm. Agreed.
Hmm. Yeah, and that is the hard part, right? It's always the hard part.
And we usually have questions like this on our exams, and I think for me, that's always like what Maisha said. That get it's like all of them are correct answers, but which one is most correct?
Right. 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 And you have this, so you can always go back and review and look at it even in more in depth and try to really, process it. And if anybody wants, I mean, I'm more than happy to get more questions like this and go over them with
Yes,
you.
yes. Thank you.
Please.
All right.
Please, as many as possible. Thank you.
Okay. Awesome. I can do that. All right. So dementia. So we talked about delirium. Delirium is reversible, right? So dementia is a slower process that results in a progressive loss of cognitive function. And it's caused by damage to the okay. It's caused by damage to the cerebral cortex. Usually it's most commonly a result of disease conditions. It is, like I said, it's progressive, it's irreversible. And so with dementia, they also have that increased potential for injury as well as self-neglect. So dementia is an umbrella term, all right? And we can break that down even further into the other types of, the individual types of dementia that fall under there. So your Alzheimer's, your Lewy bodies, your vascular, there's frontotemporal, there's others like Parkinson's and Huntington's and things that also can cause dementia. Alzheimer's is the most common form of dementia that you will see. That's anywhere between 60 and 80% of all of our dementia is Alzheimer's disease. I gotta make this a little bit smaller. Okay. Um, so Alzheimer's, like I said, is a specific disease that accounts for 60 to 80% of all of our dementia cases. And then dementia is just a term for symptoms. So like your decline in memory, your reasoning, or even your other thinking skills. I made it too big, and so now it won't change slides. So again, with Alzheimer's, this is the majority of your dementia patients have Alzheimer's disease. The brain cells are affected by atrophy, and what we call beta amyloid plaques. So it affects acetylcholine. It's affected by acetylcholine, norepinephrine, and dopamine. There's three different stages. And so these are just an overview of the three different stages. So that preclinical, with the preclinical, they don't have any, obvious signs of the dementia. With when we get into the mild cognitive impairment, that is where they start to have some mild changes in their memory, even in vision, and their reasoning. And then when we look at dementia caused by Alzheimer's, a little bit different. They have memory impairments. Behavioral symptoms are often part of patients that have dementia. Not everybody that has dementia has behavioral symptoms, but majority do. Impaired functional ability. And so, like I was saying earlier, with your Alzheimer's patients, it's a backwards, so they go backwards. So they slowly start to, they again, short-term memory is going to be the first to go, but they decline in a backwards motion. So eventually they forget things like how to tie their shoes, how to get dressed, how to feed themselves, even start to lose, bowel and bladder functioning. It's a backwards decline. So think about how you grow, right? We were born, and we learn all these things, walking, talking, eating, right, as we grow, and then it reverses when they have dementia. So with patients that have dementia and confusion, we're going to assess their behaviors. We always want to try to avoid the aggression, and, causing them to, become confused because confusion can lead to irritation and agitation and frustration, right? We want to avoid chemical or physical restraints. What's a chemical restraint?
Medications.
Melatonin.
Hypnotics, sedatives.
She went right for the melatonin, yes.
Mm.
But it even could be other medications as well, right? Any medication that is going to, cause a change in behavior, sedation, that kind of thing. Physical restraints, so vest restraints, wrist restraints, side rails, like the list can go on. We have to be very careful. We want to orient them to person, place, and time, but don't force the reorientation. All right. So you want to tell them who they are, where they are, and where, what day it is, what time it is. You don't want to force it. Again, we can reorient, but if that causes them to get irritated or agitated, you want to kind of meet them where they are. Structured environments, keeping room assignments stable. So that is something that we would try to do. Not always the easiest thing to do, right? But if we have somebody that, does have, or is declining, we want to try to keep their caregivers, as stable as possible. Routine, so that routine staffing, okay. Structured regular activities. Reminiscence is a really good one. because they can think back on those, long-term memories that they have and share their stories. And I think that's part of the greatest part about working with the older adults, as you get to hear all their stories.
You can learn a lot.
Miss
You do.
Martinez, before
Yes,
you go forward,
sure.
I have two quick questions.
Yep.
For one, would alcohol be considered a chemical restraint?
Alcohol.
Mm.
I can't imagine us giving them alcohol.
So in some facilities, at least here in Pennsylvania anyway, with doctor order, they will allow a patient to have like X amount, like so many milliliters or like so many ounces of alcohol, as long as it doesn't like counteract with their medications. But that's not every facility. That's just some facilities.
Okay. Yeah, no. Mm-mm. So yes, and we've had that. We've had, patients that have had orders to have a beer after dinner
Get like a
or
cocktail after bed, before bed. It
yes,
helps
that
them
kind of
sleep
thing.
and stuff like that.
Yeah, no, that would not, if they have a doctor's order, because, people drink, okay? And just because you're in a long-term care facility doesn't mean that you shouldn't still be able to have your drink. But no, that wouldn't be considered a chemical restraint.
Okay.
Not if they have an order for it to drink it. Yeah.
And then my second question would be, is there a reason why some people dementia progress faster than others or no? Well, I know like they usually say like people with like uncontrolled diabetes, yeah, but like besides that, is there like a reason why someone's dementia would be like faster
Some just
progressing?
have, yeah, some people for some reason just progress through it a lot faster than others. There's really no rhyme or reason for it. It's
And
just
and is that
combination of
genetic or no?
genetics and
Okay,
environment. Yeah.
okay.
Like my aunt, she had, I don't know if she had Alzheimer's, but she had dementia. And she got to the point where my uncle had to put her into a memory care facility because she was becoming more of a danger.
Wow.
She kept trying to escape. And she only made it like 3 months once she was put into the facility, which is pretty short amount of time.
So my uncle passed away on the 31st of December, but
I'm
we had
sorry.
him for the past 3 years. We got him from California, from Vegas actually. He started, they said, with early stage dementia after he had COVID. I think it was like 6 times he had COVID. So they said it was early stage dementia. But within the past 3 years, up to when he died last month, like he was so far gone to the point that like he stopped eating and
Mhm.
everything completely.
Mm.
So we had him on comfort care, and that's how he eventually passed. But that's why we had him on comfort care because he was like, he stopped eating. He didn't want to eat anything. Like every time you touch him, he would act like he would, like he's in pain and stuff like
Aw.
that. So yeah, that's why I asked. And then my grandmother, she also had dementia. She passed away 2 years ago, but it was the same thing. Like in a span of a year and a half, it was completely like
Yeah, completely different.
from not
Mhm.
from knowing something to not knowing anything at all, stop eating and drinking and everything. So
Yeah, it does. And it's just a combination of, genetics, environment as well, can just cause some to progress through it a little bit more quickly than others. Yeah. All right. Um, Medications for dementia. So there's, and you guys are in farm, took some farm already. We have what are called cholinesterase inhibitors. They block the breakdown of acetylcholine, which affects the memory and mood. So cholinesterase is an enzyme that will break down acetylcholine. So if we inhibit that enzyme, then that allows for more acetylcholine to be present. Um, and then we also have things like your Aricept, your Exelon, galantamine. I don't remember what the trade name is for that one, but they can improve cognitive and behavioral symptoms. They don't reverse, they don't cure the disease. In some cases, it just may delay progression a little bit. but it really isn't going to cure or anything like that. And then we have memantine, which is Namenda that reduces abnormal brain activity, so can be beneficial to some. Again, they're not going to cure, they're not going to reverse the disease process. They just may help to improve some of the symptoms. Parkinson's disease. And if we don't finish these, there's only a few slides left. We'll finish them when we start next week. But Parkinson's disease is it's a degenerative disorder of the central nervous system. And so this is kind of what a Parkinson's disease patient would present at. Um, they'll have a flat affect. They will have a stooped posture. Can't even say the word. When you walk, your arms swing, right? Theirs don't swing. They have reduced arm swing. They also have a short shuffling gait, so they don't pick their feet up when they walk. And then they, of course, will have the rigidity, excuse me, the tremors, are associated with Parkinson's disease as well. So all of this increases their risk for falls, right? Because they have poor balance. It also affects cognition and speech. They'll also usually have, some sort of dysphagia, so difficulty swallowing as well. Drooling is very common in your patients with Parkinson's. And it's an imbalance of acetylcholine and dopamine in the body. So some of the treatments that we use for Parkinson's, we can do stress reduction, PTOT. There's a variety of medications that we can use, but the most common is going to be that carbidopa-levodopa. Carbidopa-levodopa it helps to increase the amount of dopamine. So we try to fix that imbalance between the acetylcholine and dopamine by increasing the dopamine levels. So, all right, I'm going to stop. All right, so I will finish the last couple slides next week. I will also get you some more questions like that so we can do some more practice with those.
Thank you.
And then we will do week 5 lecture. So there's only a couple more slides left. It's another case. It's actually a case study about dementia. So we can do that next week. All right. You guys have an awesome week.
You too.
Stay
You
safe,
too.
stay
You too.
warm.
Thank you.
And I will see you guys next week.
Thank
See you.
Good weekend.
You too.